the next question actually is from you, which I think is a very relevant question. And I think both you and Dr. Pratt probably have legitimate concerns about how the prescription of Zolpidem and some of the other sedatives affect the risk profile. And I'm sure you're thinking it from both a surgical and post-operative perspective. Certainly in bariatric patients, the risk of hypoventilation. And I'll throw this back, again to someone, Kozlowski or maybe Chris. Do you see when you see patients that are scheduled for surgery or something, are there any special instructions that you give them or warn them about? And then I'll also like to ask Dr. Van der Weken and Dr. Pratt about their experiences using these hypnotics in the postoperative period. And are they particularly concerned about these?
So I'll say that I usually am fairly concerned immediately postoperatively. And one of my biggest concerns is the effect with anesthetics and whatever other narcotics we may or may not be prescribing in terms of just, respiratory depression, really more so than sleep. I think in the postoperative period, sleep's a much different animal just because of the stress response and everything that happens around the time of surgery. But I will say, for most of my patients, I do take them off of all of these medications immediately post-op, and I do take them off of most narcotics. I think the most common things that I get asked about from patients are if they can have things like melatonin. There's a small percentage of patients that will use things like gabapentin nowadays, which I know we didn't talk about too much, for pain. And what I find with these patients is, and I think other panelists have said this, that when patients believe that it works for them, there's a strong belief there. Whether it's true or it's a placebo effect is hard to tease out. Most of those formulations that they do like using are dissolvables. So they do use those, and I do let them use those. I have no issues with them using any of those medications, but we do try to actually switch them on to medications like that if they feel like they need it, versus something like this.
Right. Dr. Van der Weken, any thoughts on your end? Are you concerned about hypnotics post-op or?
Yeah, and I would put a concern even more broad than only like the postoperative period. I think in particular in these patients, but not limited to this patient group, that often it's like people would say, yeah, this is maybe a safer type of medication than some of the other sleep medications, and that then in that context it's very safe, or you cannot get any problem with that, and that's I think we should be very cautious with that kind of thoughts, because we do see that indeed they can give a lot of problem, in particular, of course, in patients with severe OSA and or obesity hypoventilation patients, but maybe also in the more mild patients, I would be afraid also in the long run for daily use, for sleeping problems, that they're not that safe, and they might give some problems of addiction in terms of when patient starts to build down the dosage, that they don't succeed building down the dosage, that they get some side effects. And I would love to see or to hear the comments from the experts on what is the true indication of the medication is.
Sure. And I'll just add to that, to your question, which is, and we'll shoot it back to the pharmacist here, is, one of the sort of suggested advantages of, let's say, Ambien or some of the Z drugs compared to, let's say, the benzodiazepines is less respiratory depression, right? And I'm interested to, is that reality? What is the respiratory depression profile of the Z drugs compared to hypnotics, and should we be concerned in that area or not? So
Actually, Jagdeep, it actually has been studied. You mentioned it before. There was actually 2 studies with Azapaclone, for example, where they looked at even moderate to severe patients, and there wasn't any worsening of Jenny Glass's activity in that study. And we've also used it in not only to increase arousal threshold, excuse me, but also in central apnea.
Mhm.
Central apnea had benefit from using Zolpidem. And I mean, the big problem with Zolpidem is obviously that it's relatively short acting. That's why obviously this, ambient CR. But in the average patient, it's not an issue in terms of respiratory depression. The question is when you post-operatively, I don't think it's ever been studied. And if they're on other medications, that might be a different story. So that really, I would be very cautious post-operatively with that. But in terms of the average OSA patient, I use it actually a decent amount. And the other Zapaclone study there was 2 actually. One was improvement in CPAP titration. The other one was just in tolerability of CPAP with the use of Zapaclone. And like I said, it didn't worsen OSA, but in the post-operative patient, who knows? All bets are off. Like I said, I don't think it's been formally studied.
Chris, any thoughts on respiratory depression and the Z drugs or benzodiazepines? Do you get concerned when somebody comes into your pharmacy with these prescriptions?
Well, the concern with the benzos is that you're going to see tolerance to them, and you're going to have increased dosing as you move on with them. So you can increase risk with that. So with the Z drugs and, especially Zolpidem, you don't see that as much. You don't see the tolerance buildup that you would see with the benzos. So you see Zolpidem used more frequently, but I also see it overprescribed. I mean, patients are using it for long terms, and I think they're just taking it more as a crutch than they are as taking it for actual sleep at that point. So the concern would be the long-term use of the non-sustained release products.
Well, one of the things I just would make mention, it was actually very interesting, not to go back to Suvorexin. You're going to think I'm harping on Suvorexin, but it was actually a very interesting EEG power spectral analysis where they compared Suvorexin to other sleep tonics, including Zolpidem. And I'm not too draconian about it. If I have a Zolpidem and they're doing well, I never think twice about it. But what it showed in this study was that you can actually have a real disturbance in sleep architecture with these other drugs. And that's also a consideration. But my rule in general is that patients take it, they sleep well, and most importantly, they're functioning at a high level during the day. They're not forgetting things, they're not out of it, they're not groggy. Then I'm pretty comfortable with it. But it is sort of an interesting question. I mean, I could find the reference to that article. It's a weird one because it shows how crazy the sleep architecture can be with average sleep medicines, including trazodone actually was looked at in that study.
Right. Okay. Wonderful. Thanks for that discussion. I think obviously, insomnia is a huge issue, and we sort of worry about it, in many ways.